Most people believe heart attacks give you a warning, a sharp pain, pressure in the chest, something dramatic that tells you something is wrong. But after 60, that's often not how it happens. Some of the most dangerous cardiac events happen quietly, not while you're active, not while you're stressed, but while you're asleep. No warning, no time to react, no second chance. And here's the part that surprises almost everyone I talk to. These events are often not random. They are shaped by something very ordinary, something you likely did just a few hours before you went to bed. A late dinner, a skipped or mistimed pill, a room that was just a little too warm, a body that went to sleep slightly dehydrated. None of those feel dangerous in the moment. That's exactly why they get missed, because what your body needs at night is very different from what it tolerates during the day. During the night, your system is supposed to slow down, repair, and reset. But after 60, that system becomes more fragile, less forgiving. And when certain habits quietly push in the wrong direction, the risk doesn't show up immediately. It builds, especially in the early morning hours when blood pressure and stress hormones begin to rise again and your cardiovascular system is at its most vulnerable. Tonight, I'm going to walk you through 5 common evening habits that may be putting unnecessary strain on your heart while you sleep. And more importantly, how small, realistic changes can help reduce that risk. Because this isn't about fear. It's about finally understanding what your body has been trying to handle quietly every single night. If you look at how evenings typically unfold for many adults over 60, a few patterns tend to repeat. Dinner is often later than intended. Not unusually late, but commonly in the range of 8 to 9 p.m. The meal itself is usually complete. Carbohydrates, protein, sometimes heavier preparation. Nothing extreme, just a standard evening meal. After that, activity levels drop. Sitting becomes the default. Television, reading, or simply resting. Within a relatively short window, the body transitions towards sleep. Fluid intake also tends to change in the evening. Many people reduce how much they drink after dinner. This is usually a deliberate decision, aimed at avoiding waking during the night. Sleep itself often appears uneventful. There may be no obvious disturbances, no clear signs of discomfort, and no symptoms that would immediately raise concern. But the next day can reflect a different pattern. Morning energy is often lower than expected. Alertness may take longer to build. By late morning or early afternoon, a gradual decline in energy is common. This pattern is frequently interpreted in simple terms: age, sleep quality, or daily demands. What is less often considered is that these daytime patterns may be influenced by physiological processes that begin the night before. Not in dramatic ways, but through small, repeated conditions that affect how the body transitions into its overnight state. What matters most here is not the habit itself. It is how the body is designed to function at night, and how easily that design can be disrupted. During sleep, your cardiovascular system is not simply resting. It is operating under a different set of controls. Blood pressure is expected to drop by about 10 to 20%. Heart rate slows, blood vessels relax. This pattern is not optional. It is part of how the body protects the heart and the brain over time. This process is driven largely by a shift in the nervous system. At night, the body moves into a parasympathetic state, a recovery mode where repair, regulation, and energy balance take priority. But after the age of 60, this system becomes less stable. Blood vessels are less elastic. Pressure regulation is less precise. The nervous system does not shift as cleanly between states as it once did. That alone narrows the margin for error. Now layer in another factor: circadian timing. Your body does not handle food, stress, or metabolic load the same way at night as it does during the day. Insulin sensitivity is lower. Glucose is cleared more slowly. The same meal that is manageable at noon places a different demand on the system at 9 p.m. This is not a preference issue. It is a biological constraint. And then there is the early morning transition. Between roughly 4 and 6 a.m., the body begins to shift again. Stress hormones such as cortisol start to rise. blood pressure increases in preparation for waking. In a healthy system, this transition is controlled. But in a system already under strain, with stiffened vessels, altered blood flow, or unstable regulation, that transition becomes a point of vulnerability. This is when plaques are more likely to rupture, when clots are more likely to form, when events occur without warning. So the issue is not simply what happens during sleep, it is whether the body is entering that period in a stable state or in a condition that it cannot safely compensate for. One of the most common patterns I see, and one of the most consistently underestimated, is the timing and size of the evening meal. A late dinner does not feel harmful. That is precisely the problem. From a physiological standpoint, eating a full meal within 2 to 3 hours of sleep places the cardiovascular and metabolic systems under load at the exact time they are supposed to be reducing activity. After a meal, blood flow is redirected toward the digestive system. Heart workload increases to support that process. Triglyceride levels rise within a few hours. Glucose enters the bloodstream and must be regulated. During the day, the body is equipped to handle that demand. At night, it is not. Insulin sensitivity is lower in the evening. Glucose clearance is slower. The same meal produces a higher and more prolonged metabolic response than it would earlier in the day. This creates a direct conflict. The body is attempting to enter a state of reduced pressure, slower heart rate, and vascular relaxation, but digestion is pushing in the opposite direction. Higher demand, higher circulation, ongoing metabolic activity. In younger individuals, this mismatch is often compensated for. After 60, compensation is less reliable. Blood vessels are stiffer. Regulation is less precise. The system has less capacity to absorb conflicting demands. This is where the risk accumulates. Elevated nighttime blood pressure, delayed metabolic recovery, increased likelihood of reflux, which can trigger or mimic cardiac symptoms. And critically, this state carries into the early morning window when blood pressure begins to rise again and the system is already under strain. This is not about extreme eating, it is about timing. A routine that feels normal, a full dinner at 8:30 followed by sleep at 10, is biologically a repeated stress signal. Not dramatic, but consistent. And over time, consistency is what drives risk. There is a second pattern that is less visible but clinically more serious. It has nothing to do with what you eat or how you sleep. It has to do with when your blood pressure is actually controlled. Most people assume that if they take their medication in the morning, the problem is handled. From a medical standpoint, that assumption is often incomplete. Blood pressure does not remain constant over 24 hours. It follows a rhythm. In a healthy pattern, pressure rises after waking, stays elevated during the day, and drops at night. That nighttime drop is not optional. It is protective, but a significant number of adults over 60 do not follow that pattern. Blood pressure either fails to drop or rises during the night and early morning hours. This is referred to as nocturnal hypertension. In many cases, it goes completely undetected. No symptoms, no warning signs. But the physiological impact is very real. During sleep, the vascular system is not in a high resistance state. The arterial walls are more vulnerable to pressure-related stress. If blood pressure remains elevated or increases during this period, the risk of plaque instability and clot formation increases. This is particularly relevant in the early morning transition, when blood pressure begins to rise again under the influence of cortisol and sympathetic activation. If baseline pressure is already elevated at that point, the combined effect is not additive, it is compounding. Here is the mistake: treating blood pressure as a daytime issue only. Taking medication without understanding whether it is actually covering the hours of highest risk. For some individuals, morning dosing is sufficient. For others, it may not provide adequate coverage overnight. That difference is not theoretical. It depends on individual blood pressure patterns, which means this cannot be assumed, it has to be evaluated. Ignoring this timing issue does not produce immediate symptoms, but it does create repeated periods of unprotected exposure during the exact window when cardiovascular events are most likely to occur. This is the pattern most often dismissed and the one with the clearest evidence of harm. Snoring is not just a sound. In many cases, it is a marker of obstructed breathing. What is often overlooked is that in obstructive sleep apnea, breathing does not just become noisy, it repeatedly stops. Airflow can pause for 10, 20, sometimes 30 seconds or longer, and this can happen dozens of times per hour. Most individuals are not aware of it. From a physiological standpoint, each episode follows the same sequence. Airway collapses, oxygen levels in the blood begin to fall, the brain detects a threat and activates a stress response, heart rate increases, blood pressure rises abruptly, stress hormones are released. This is not a mild disturbance. It is a repeated cardiovascular event. Over the course of a single night, this cycle may occur hundreds of times. That repeated pattern produces cumulative stress inside the vascular system. Intermittent drops in oxygen contribute to oxidative stress. Endothelial function becomes impaired. Blood pressure regulation becomes less stable over time. There is also a metabolic component. Sleep apnea is associated with reduced insulin sensitivity and impaired glucose control. This links it directly to the same metabolic pathways that affect cardiovascular risk. The mistake is treating snoring as a benign habit, or assuming that feeling somewhat tired the next day is simply part of aging. From a clinical perspective, persistent loud snoring, observed pauses in breathing, or waking unrefreshed despite adequate time in bed are not minor findings. They are indicators that the body is not maintaining stable oxygen and pressure levels during sleep. And when that instability is repeated night after night, it places continuous strain on the heart and vascular system during the exact period that is supposed to be protective. There are two additional factors that are often treated as matters of comfort or convenience. From a physiological standpoint, they are not. Hydration. Many adults deliberately reduce fluid intake in the evening. The reasoning is understandable, to avoid waking during the night. But the assumption behind that decision is that mild dehydration is harmless. It is not. When fluid intake is reduced, plasma volume decreases, blood becomes more concentrated, viscosity increases. In a younger system, this may have minimal impact. In an older vascular system, where arteries may already be narrowed or less elastic, this changes how blood moves through the circulation. Flow becomes less efficient. The likelihood of clot formation increases. Now consider the timing. During sleep, heart rate slows. Circulation is already reduced compared to daytime levels. If blood is more viscous under those conditions, the system is operating with both lower flow and higher resistance. That combination is not neutral. It is one of the contributing conditions associated with the clustering of cardiovascular events in the early morning hours. The mistake is not hydration itself, it is assuming that reducing fluids in the evening has no physiological cost. Room temperature is typically adjusted for comfort, but the cardiovascular system responds directly to thermal conditions. If the room is too warm, the body must dissipate heat. Blood vessels dilate, heart rate remains elevated, fluid loss increases through perspiration. This interferes with the expected nighttime reduction in cardiovascular activity and can worsen dehydration. If the room is too cold, the response is different, but equally relevant. Blood vessels constrict, peripheral resistance increases, blood pressure rises. For an individual with existing vascular stiffness or hypertension, this creates additional strain during a period when the system should be under minimal load. Temperature also affects sleep architecture. If deep sleep is reduced, the cardiovascular system loses a critical window of recovery. The mistake here is treating temperature as preference rather than physiology. A room that is slightly outside the optimal range does not cause immediate symptoms, but it alters vascular tone, heart workload, and recovery quality in ways that accumulate over time. The issue here is not a lack of discipline. It is a mismatch between how the body actually functions and how it is commonly interpreted. Most people evaluate their health based on what they can feel: energy, sleep quality, obvious discomfort. But the systems we are discussing do not operate at that level. Blood pressure patterns during sleep are not perceptible. Oxygen fluctuations from airway obstruction do not produce clear awareness. Changes in blood viscosity or vascular resistance are not sensed directly. These are non-sensory processes, which means they can be significantly disrupted without generating any immediate feedback. That is where the misunderstanding begins. Normal perception is taken as evidence of normal function. From a clinical standpoint, those are not the same thing. There is a second layer to this. Many of the behaviors involved, late meals, reduced evening hydration, irregular sleep conditions, are evaluated based on convenience or habit, not based on timing relative to physiology. A behavior that is tolerable during the day is often assumed to be equally tolerable at night. That assumption is incorrect. The body does not process metabolic load, fluid balance, or vascular regulation in the same way across the 24-hour cycle. What matters is not just what is done, but when it is done. A third misunderstanding is how risk is interpreted. People tend to associate risk with intensity, something severe, something acute, something noticeable. But in this context, risk is driven by repetition, a condition that is slightly misaligned with physiology, applied every night over years, produces a cumulative effect, not dramatic in any single instance, but clinically significant over time. The result is a pattern where nothing feels immediately wrong, yet the underlying systems are consistently operating outside their optimal range. That is not a failure of awareness. It is a limitation of how the body signals internal stress. At this point, the goal is not to overhaul everything. It is to reduce the mismatch between behavior and physiology. That starts with timing. Evening meal timing. A consistent adjustment here has measurable impact. Finishing the last full meal at least 3 hours before sleep reduces the overlap between active digestion and the body's transition into its nighttime state. This allows blood pressure, heart rate, and metabolic activity to decline more appropriately. The change is not about eating less, it is about shifting when the metabolic load occurs. Blood pressure pattern awareness. For individuals with known hypertension or those at higher risk, what matters is not just whether blood pressure is treated, but how it behaves over 24 hours. Home monitoring at different times of day, including evening readings, can provide a more accurate picture than isolated daytime measurements. In some cases, clinicians may recommend extended monitoring to evaluate nighttime patterns. This is not a routine assumption. It is a targeted evaluation. Sleep disordered breathing, persistent, loud snoring, observed pauses in breathing, or waking unrefreshed despite sufficient time in bed are indicators that warrant objective assessment. This typically involves a sleep study. The purpose is not labeling, it is identifying whether oxygen levels and breathing patterns remain stable during sleep. Because if they do not, no amount of sleep duration will correct the underlying issue. Fluid balance, evening hydration does not need to be excessive, but it should not be intentionally minimized to the point of creating mild dehydration. A moderate intake earlier in the evening, with adjustment closer to bedtime if needed, helps maintain plasma volume without significantly increasing sleep disruption. Sleep environment temperature should support physiological recovery, not interfere with it. A slightly cool, stable environment helps maintain appropriate vascular tone and supports deeper sleep stages. This is not about preference. It is about reducing unnecessary cardiovascular demand during the night. None of these adjustments are extreme, but they address the same underlying issue. The body is being asked to do the wrong things at the wrong time. Correcting that does not require intensity, it requires alignment. What we've covered isn't dramatic. It's subtle patterns the body is dealing with every night. Blood pressure that doesn't fully settle, breathing that isn't consistently stable, metabolic load happening at the wrong time. You don't feel these directly, but they are known to increase cardiovascular stress during sleep. The real issue is not what you notice, It's what your body is handling without telling you. Don't rely only on how you feel. Start paying attention to when your body is being asked to work. One small adjustment done consistently has more impact than occasional effort. If one part of this sounded familiar, don't ignore it. That's usually where the problem begins. Comment night and your time right now. I want to see how many people are watching this during the exact hours their body is most vulnerable.